viral load testing services. And as such, given that most countries were having gaps, we decided to form a sub-community of practice to at least help the countries in terms of learning best practices from those countries that are already having systems in place, and also having some technical assistance through South-to-South assistance. So now I'd like to welcome Michael Maina Waweru, who is the M&E lead for the LabCoP, to take us through a very interactive presentation. And if you have any questions, please put them in the chat box and we'll be able to answer at the end of the session. Otherwise, welcome, Michael. Over to you.
Let's get started. Good morning, good afternoon, good evening, colleagues. I'm going to walk us through this presentation on introducing the M&E subcommunity of practice. I believe I have been in communication with a number of you, and I'll straight go to the presentation, and the presentation will highlight a number of things. The first thing that I'm going to highlight is the issues to do with viral load testing continuum. We're going to look at the rationale that informed the M&E subcommunity of practice. And then we have some discussion on data element and the source for data for tracking various VL cascades. Fortunately, a number of us participated in a number of country assignments. We're going to look at we're going to look at what is going on and what are we finding out. And then we're going to discuss how we are going to be engaging as we implement the sub-community of practice. If I go straight to the presentation, I'll shoot straight to the first part of the presentation. When you think about viral load testing, there are many processes that are basically involved in it. From people living with HIV who are eligible for a viral load test, they assess the health facility, they get tested, the samples are collected, the samples are transported, all the way to the result being returned to the patient or to the client. And within there are so many stakeholders that are involved, from the laboratory staff, program managers, civil society, and implementing partners. All of them are working toward facilitating that process. And of course, that whole thing is backed up by a system that has different components as highlighted. And the whole idea here is that if someone, for example, the outcome of the viral load test is that the person is suppressed, then you'd want that person to be moved to a less intense model of care. And that's why we have been having what we call the differentiated model of care. In an event that person is having elevated viral load or is not suppressed, then there are a number of interventions that basically kicks in. We have the intensified rehearse counseling. We again test that person again to see whether they have been suppressed. And in an event that they're not suppressed, then for some countries that have no doubt drug resistant testing that happen, all of that is not there, then the person is switched, the regimen is switched. So in an event that the results are not being utilized, then it becomes extremely difficult to figure out what could be going on. Why are the results are not being utilized? Maybe the results are not being utilized because they're not being returned. It could also be that the tests are not being requested. It also could be that there are a number of challenges within the support system, and therefore that's where result utilization is becoming a challenge. And if you look at it, the continuum that I've just highlighted, you're thinking about from the time the demand for HIV test is done, to the person visiting the health facility, to the specimen being sent, that viral load testing continuum becomes an extremely important component for you to have it in the back of your mind when you're thinking about M&E for viral load. And we say it becomes therefore extremely critical that monitoring of this continuum gives you some very important data. Number one, it tells you, are the clients being managed as they should? And number two, how effective is your HIV program? Now, you cannot comfortably answer these two questions if you're not utilizing the results for viral load. And as I've just highlighted in the previous slide, there could be a number of challenges that could be there within the system that is interrupting the utilization of these results. And as you are thinking about how well to utilize the results for viral load, there are a number of indicators that then basically kicks in. There are indicator that touches on availability of the tests themselves. Are the tests being available when they are needed by the clients? Are the client accessing those tests? To what are there people who are not getting the test? The coverage questions basically kicks in. Then you also ask yourself a question that touches on the quality of the test itself, both the quality of the test that is being provided, but also the quality of the data that you're collecting. And finally, you also ask yourself, what indicators for result utilization do I have to factor in? Because this become important because it's involving it is informing a number of things, including the policy direction that the country is adopting, to know how effective the program is like. It also involved the quantification that we're doing for various things that are needed within the continuum. So bottom line, what we are saying, it therefore follows that viral load measurement is an asset that is too precious to waste. Now, whenever we think about an M&E of any program, there are ideally about 5 or so steps that are involved. So you think about, I need to assess my program. In this case, I need to assess my lab program, particularly the way the viral load is being provided. And when you are there are many various tools that are used for assessment. There are, for example, there's the laboratory assessment tool by WHO, the LabMap tool that is also used, the LabNet tool. There are various tools that are used to assess the network. That's why you start. You are doing an assessment the idea is you do want to identify where is the problem. And there are various tools that currently exist that we can, as a community of practice, we can tap on to assess the various aspects of our network. And after you have assessed your network, the next thing that basically kicks in is how you start doing the planning. You're identifying areas that the objective that you're going to work towards. That's step number 2. And then step number 3, you design targeted interventions. What interventions am I going to do to collect whatever my assessment findings were? And of course, you go out and you do your implementation, and you evaluate how effective your implementation has been, and again, you assess again. So this becomes a continuous cycle that you're continuously doing. And therefore, M&E for viral load becomes a critical component when you're thinking about scale up of viral load or viral load implementation. And by extent, when we sort out the viral load system, and we have said over and over again that we are currently using viral load as an entry point, because as you strengthen the viral load system, then you also end up strengthening other component of the lab network. Now, within ASLM, we also work with the countries so that the countries can assess themselves, and we use a rapid assessment checklist. And all the checklists that I've mentioned in the previous slide, all of them use some kind of capability maturation model, whereby you want to see how the cycle is improving. Now, the tool that I mentioned about, and countries that are represented here, we do this assessment once every year. The tool has various domains, as I highlighted, from demand creation all the way to leadership. And finally, there is what we call national data on viral load. And that's the component that I would want to highlight. We basically ask countries to highlight to us the indicators that are listed from 7.1 all the way to 7.2. And there are various kinds of indicators. And these indicators are extremely important for a country that is tracking the performance across the various cascades. So we are interested in indicators, for example, how many laboratories that are performing laboratory tests? What machines are they using? What kind of testing capacity do they have within that they can test within 1 year? And how many tests have they conducted within the last 12 months, so that we can match the capacity versus the utilization? Once we look at the issues with labs and the testing equipment and the number of tests that they're able to do, then we enter the other cascade that touches on the people living with HIV. And we're asking ourselves, from how many people are currently estimated to be living with HIV in a specific country, in the country that we are collecting data from, or the country that is doing the self-assessment? And of those people who are estimated to be living with HIV, and that comes from national level estimate that country does on annual basis. Then from the people living with HIV, we ask ourselves, how many people are currently on ART? In other words, we are trying to see how many of them have been put on treatment, what we call the second 90. And of those people who are on treatment, how many of them are on fast ART regimen? So we ask countries basically on annual basis, they sit down and look at these indicators. And as we have seen, all those indicators travel from those people on fast ART regimen, those who are getting available test results, those people who are suppressed. And if you're suppressed, have you been moved to a less intense model of care? If you're not suppressed, are we doing enhanced adherence? If we have done enhanced adherence, have there been a repeat viral load? And after the repeat viral load, are you suppressed? And if you're suppressed, we move to less intense model of care. If you're not suppressed, then what do? We switch regimen. So countries do this assessment every year, and this has been the finding. For example, this is the assessment that they did last year. I've not named the countries, but all of us are represented here. Basically, I named them country number 1 to country number 12. And one of the areas that we realize, there are a number of legs that we can see in this presentation. And I've highlighted the last five indicators for us, especially the M&E team here, to see that a number of countries, or majority of the countries, are struggling in the last number of 5 indicators. Those people who have been moved to a less intense model of care, those people who are not suppressed and they receive enhanced adherence, those people who had a repeat viral load, those people who were suppressed, and finally those people who switched. And therefore, for us, as we continue to engage for the next number of months, the question that we need to ask ourselves is, how do we make sure that this data flows to the national level, is available at national level for use, and the country is continuously using the data to make decisions. For example, if you pick this indicator right here, the one on less intense model of care, a number of countries that we are coming from are involved in the sequence processes, and therefore it will be a good avenue for us as a team to say, one of the indicators that we're going to change is the availability of data on less intense model of care. We are going to make sure that data is flowing at the national level. And if then that becomes a goal for us to work toward, the question that we have to ask ourselves, do we have the accompanying tools? What processes do we need to put in place? Those are the kind of conversations that we'll be having as we continue implementing the M&E subcommunity of practice. Now, you realize that if the above indicators are not corrected, then the country finds itself with a number of challenges. And a number of challenges that then arises would be, one, the ability to design targeted intervention to improve the cascade. That is affected because unless you have this data, unless you get to know how many people have been switched, for example, unless you know how many people on what kind of model of care, then how then are we going to have these targeted interventions? Then, if this delay also has implication in the achievement of the that 95, now we are 95, 95, 95, a country start experiencing challenges in quantifying the performance and in achieving the 95. For example, if we don't know that people are getting enhanced adherence, if you're not suppressed, or they are being enrolled less intense model of care, or they are getting switched to treatment, then the question on that 95 start becoming a little bit difficult for country to answer. And of course, then it also becomes extremely difficult for a country to answer questions related to epidemiology of HIV. And what I think the emphasis that I'm making here is the team, because we are here representing different countries, expertise in our own field, people who are extensively experienced. We need to work together to make sure that this picture that I have highlighted in this slide, we gradually change the picture from the country that we are coming from. Now, I go now to the 2 cascades that I have spoken about, but I would want to speak about from an M&E perspective. I talked about the number of people living with HIV. This is normally an estimate. So sometimes you get to know that this is the estimated number of people living with HIV in a specific country. Now, then you start asking yourself, according to national algorithms, how many people should get a test at least once every year? Now, if different countries have different guidelines, WHO has its own guideline, but then that becomes a question that we ask ourselves. Then we're asking ourselves, how many people now are accessing viral load? And of those people who are accessing viral load, how many people are getting tested? Of those who are getting tested, how many of them are federally suppressed? And of those people who are federally suppressed, how many of them have we moved to a less intense model of care? Now, this component here on less intense model of care is one of the areas that we find a number of countries are struggling. So we have to ask ourselves as a community of practice, where is this data? For example, where is the data across, where, if you want to know how many people are on ART, for example, is the data being collected by the country comprehensive enough? Does it cover all sectors? Is the private sector, for example, included? What are the reporting rates from all the sites? So that's the conversation that needs to happen within the country, between countries, so that we can learn from each other as we continue with the implementation. Now, among the patients who are not federally suppressed, the second cascade basically kicks in. And this cascade basically says that if you are not federally suppressed, then we put you on enhanced adherence. And once we have gone through the enhanced adherence processes, then a repeat viral load is done. And if that repeat viral load, the outcome is that you are suppressed, then we put you on less intense model of care. And by default now you belong to the first cascade. But if you're not, if whatever is on the follow-up viral test is not suppressed, then we are saying there's an aspect of being switched to the other line of regimen as per the country guideline. And after you have switched to you, if you get suppressed, then I believe you can get the picture. And as you have seen in my previous slide, this is one of the 5 indicators that I highlighted basically are touching on this second cascade. So the problem starts in the first part of it, whereby we are talking about people being taken to a less intense model of care. But then the problem becomes a little bit more challenging here, where we are having countries, this data not flowing to the national level. And therefore, as we continue engaging for the next number of months, one of the initiatives that we want to put in place is how do we make sure that this cascade is complete at the national level? What system exists, for example, in the country? What can we learn from each other? There might be a country that is doing extremely well in this area. How can we then learn from each other and borrow, adapt and to a country context, so that gradually we are getting the whole picture of what is going on in the country? Now, I'm going back to this cascade continuum of viral load, and I'm doing that because it's extremely important for us to focus here. Remember, we are thinking viral load, we are thinking that 90, and when we think about that, although we are sitting, majority or all of us are sitting at the national level, we have to start our thinking at the site level, almost at the community level, where demand creation is happening. The patients are walking to a health facility. The clinician is interacting with the patient, and they are collecting sample for testing. The samples are being sent to the central lab or whatever testing is happening, and the results are being processed at that point. And when the results are out, then the results are being relayed back to the health facility. And how long do those results take before they can get back to the caregiver or the client himself or herself? Because the recipient of care, we are doing this so that they can receive the best quality of care. Now, if you look within your country, I would want for us to pause for a minute, and probably I'll invite whoever want to give us example from their country to basically highlight to us how is the M&E framework designed in your country? How is it that and in a very simplified way, how is it that you have attempted to capture the various components that are involved from demand creation all the way to going to the lab, and then that result getting back to the healthcare provider and the recipient of care? So I would want us to take about 3 minutes, and then a number of you please post how you have done this, how is it structured within your country. I'll invite whoever it is who want to speak, please raise up your hand and speak as I grab a glass of water. I'll pause it here for about three or so minutes. Thank you.
Hi, Faith, you can go ahead.
Thank you, Anafi, and hi, everyone. Good afternoon. Happy to be here and happy to have all of you in the new year. Michael, thank you for the question that you have posed. I think for us, it's just to share that as a country, we have a specific M&E framework for the lab, and the combined M&E framework does not just look at the HIV and viral load aspect, it looks at all the areas that are captured under the lab section. But again, to narrow it down for the HIV area, we have what we call the Kenya AIDS Strategic Framework, and alongside it, we have developed an M&E plan. And in this plan, it covers all aspects of care and management, which includes viral load measuring. So what we need to measure has been captured in the M&E framework under what we call CAS for Kenya AIDS Strategic Framework. But again, there's a component that is captured under the combined lab M&E framework, which looks at all the laboratory work, not only for HIV, but all the areas that are covered under the lab. I think that's just what I would like to share from you. But one of the things is that the two documents kind of talk to each other because the measurement indicators are similar across.
Yeah, thank you, Faith. Collins, I don't know whether there is anyone else who want to hand it up. Could we hear from another country? Let me ask Kingston. Kingston, how is it in Nigeria? Kingston? Well, as you're waiting for Kingston to unmute, I'm trying to see whether there's anyone else who has raised their hand. Is there another country that would want to share how the M&E framework is structured in their country?
There's Elvis raised.
Again, Collins?
I think Elvis wants to ask a question.
Okay, go ahead.
Comment.
Go ahead, Elvis. Please unmute yourself.
Elvis, go ahead.
Thank you, Michael, and thank you, Collins. Thanks again, Faith. I think just to add on is that currently the country is undergoing what you call, they want to do the viral load strategic plan that had expired. It is a scale-up plan, so we are in the process of getting a strategic plan. We will have an M&E component under it for viral load.
Thank you. So in the interest of time, I'm going to proceed, but I'll be asking some few questions as we move along. So I borrowed this. It's an extremely busy slide, but I borrowed this slide because it basically touches on what we have been speaking about. So at the facility level, there are various tools, from the one that the clinician is using when the clinician is ordering for viral test results. And then there are a number of tools that then are at the hub level and the central level. And eventually there are a number of tools that exist back at the facility level when the results are transmitted back. And those tools can either be found within the electronic medical registers, or they could be in the patient charts. But there are various tools that are recommended for use for management of patients or clients living with HIV, and especially when you are thinking about viral load. And then at the national and the subnational level, there are various kinds of systems that are there. A number of countries have DHIS platforms. We might be having laboratory information management systems. So there are various guidelines and recommendations on tools that need to be put in place, and how that data need to flow from facility to the central hub, to when it gets tested, going back to the facility again, and how does that data get aggregated and used at the national level. And the conversation that we'll be having for the next number of months up to July, we'll be looking at how do we then strengthen these systems, so that as we sort it out for viral load, we are able to sort out for other lab interests and other diseases that laboratory system is engaged in. Now, a country then that has good systems in place, then you are able to have very nice dashboard. And a dashboard, the beauty of a dashboard is how it increases greatly access to data, and it also increases the extent to which data is being used to make decisions. For example, I picked these two examples, and they are from countries. I'm very sure probably a number of you from country A and maybe country B, you can identify your dashboard. I have not named where this came from, but basically I'm highlighting these two dashboards because they are used at the national level. And you can actually see, by just looking at it, there are a number of questions that you can answer. For example, you can see in this particular one, a number of 1.3 million tests were conducted last year. This was 2020. And you can actually, then you start answering a number of questions. How is population looking like in that country? How are some samples are being rejected? Where are they being rejected? What is going on? What is population rate like? And therefore, the case for the need for having data flowing at national level, it become a little bit easier for policymakers, for everyone who is involved in that process to make decisions. And it's the same thing for this other country here. You can see the number of samples that have been received. Yes, the dashboard have different kind of information, but you're able to see that 88% of these people accessing who got tested were on first regimen. So even if you are involved in forecasting and quantification for ART in that country, then you are able to see what kind of orders are you supposed to be having in your pipeline. I put this here to say that indeed, looking at it, there are a number of information that we can pick from each, and there are a number of decisions that this dashboard support. And therefore, every one of us who is in this M&E subcommunity of practice, it therefore is upon us to ask ourselves, how do we facilitate the conversation on having a national level dashboard? If the dashboard is there, does it need some level of improvement? How is the data flowing to the dashboard? Where are we getting the data flow? Is there any data that is not flowing? How can we make it flow? Do we have electronic medical registers in our country? Is that data, do we have a national data warehouse, for example? And in absence of, if the country has not, the system within the country has not matured to that extent, how then can we make use of what is existing within the country? How then can we make use of what is existing within the country? Or how then can we learn from another country that seems to have implemented a dashboard of some sort? Now, when we started the conversation on having an M&E sub-community of practice, we agreed that we sent a survey to countries, and the response from the surveys came, and the question that we're asking countries is, from the data that you have at national level, what are some of the questions that you can answer? And the question are highlighted here, and I hope it's not very busy, but I'm going to eventually zero in on the one that I led. So we wanted to ask, can you tell the difference in suppression between men and women? Do you know which sites, how the sites are performing in terms of suppression? Do you know about how rejection of samples is happening within your system? Those kind of questions as I highlighted here, but I would want to zero in a number of them in my next slide. But as you see, all of us, there are a number of questions that we can comfortably, adequately answer at national level. But then you start seeing some lead in some areas, and two of them that are completely lead. What percent of non-suppressed patients underwent some form of enhanced adherence? And among those people who went through enhanced adherence, how many of them were suppressed? Now, this data is an extremely important data at national level in informing decision making, and this is why I put these particular 5 indicators, because this is where we seem to be struggling. The country represented in this session, we seem to be struggling in this indicator that I highlighted here. Number one, we need to ask ourselves, as we continue engaging the next number of months, how do we take advantage of the sequence processes, for example? How do we make sure that at any given time at national level, we are able to tell how many people are on less intense model of care? How then also are we able to ask the question among the people how then are we also able to answer the question among the people who are not suppressed, how many of them underwent enhanced adherence counseling? So this question that I highlighted here, I would want us to make this our pet subject for us to change as we continue implementing. And I would want to take another 3 minutes, and the question that I would want us to ask ourselves, because these are the areas that we are struggling in, why is it difficult to get data to these questions? That's the question, our question number 1. And number 2, the next thing I would want to hear from a volunteer in this forum is, what can we do to remedy this situation? So 2 questions. So I'll again pause for a minute. As I said, we're going to continue having this discussion, and we're going to have this discussion and as we move along. But I would want to hear from 2 volunteers on these 2 areas. Why is it difficult to get data, and what can we do to remedy this? Let's take 2 minutes to think about it. And please, I can see already a hand is up. Please go ahead and unmute. Collins, please call the participant. Is that harder?
Yeah. Thank you so much, Michael. I'm Drat Akbar from South Sudan. I think regarding the question you are raising, we are unable to answer these questions because we do not have our data collection tools capturing this particular data element. So from program perspective, you would find at facility level, a lot of interaction happens when it comes to enhanced adherence counseling, when it comes to switching clients from the original first line regimen to the second line regimen based on non-suppression, but then this is not being documented in the source documents from which we could obtain this data. So our source documents are not capturing this, then our monthly, weekly, or quarterly reporting forms are not also capturing this. So one way to address this is to review the data collection tools and try to restructure the registers to capture this, and then revise the monthly reporting forms also to be able to pull this kind of data. But this will also have implications on any digital platforms on which data is being collected. That means we would have to get to the PHIS2 system to also review customization of the monthly reporting form so that we are able to get this. Thank you.
Thank you so much. I'm looking for hands that are up. Collins, I need your help here. I'm not able to pick them as fast.
Faith, are you able to unmute?
Yes, I've unmuted. Okay, just
ahead.
to, thank you, Collins. To share our experience, I think we've made an attempt to capture part of the DSD models on our primary data source. That's the patient record card that is used at facility level. And as well, we have gone further to put it in our monthly summary tool. That's what we use to enter data into KHIS. However, there still stands a gap in terms of completing the data elements that have been identified. And as a result, I think it would revolve around capacity building of the healthcare workers to better understand these elements that need to be collected, and then also to ensure that we improve our tools to give us a bit more detailed data, much as it is aggregate data in regards to the DSD models. Because what currently exists, it's very minimal, probably just says whether you are community-based or it just has two options. So it's really minimal information that is available. So if we look at ways in which we can improve on our summary sheet, that would be ideal, and also ensure that we capacity build our healthcare workers to understand some of these elements and the reason why we need to report them. And for the attempts that have been made through the electronic systems, I think the data from the EMR is quite good and is very detailed because it gives you at patient level. So again, it's also just looking at an aspect of how do we summarize so that we can be able to view them on our dashboards. About enhanced adherence, I think this is zero capture, but again, it also sits in our primary data source. That's the patient record card. But now we have to look at means to collect this data either at aggregate level or even through the EMRs, which is case-based data. But again, we still need a summary that can be reflected on the dashboard. Thanks, and over to you, Michael.
So thank you, Faith, and thank you, Blade. It's great to hear experiences both from Kenya and South Sudan. And as I was saying, and we are going to continue having this conversation. There is a session that is pure dedicated for us to discuss about tools and indicators. But I wanted to us to start thinking about our system now. Ask ourselves, what is it that we can improve within our system? Because if I'm hearing correctly, there are conversations that will need to happen within the next number of months, conversation that touches on the tools that we are using to collect data. Other conversation will touch on the systems that have been put in place to collect these data, may be electronic medical register, for example, and how is it that we can make that data gradually flow to national level to help in decision making. Now, I would want to proceed in view of the amount of the time, but we also pose this question to the country teams. And some of the areas that, as you can see, this graph here shows what country reported to have in either a tool or a system. They have request forms, but one area that majority of the countries seem to having challenges is the issues of high viral load registers and logbooks. And that explains why then we're having a challenge almost all of us, in tracking the second cascade. And therefore, as I've said in my previous slide, that then this becomes one of the key conversations that we shall be having as we continue implementing and as we continue engaging in the next number of months. Now, if you look within your country, given what I've just highlighted, there are definitely so many actors that are involved in collecting and analyzing and reporting data for M&E. And they may be clinicians, for example. There are many people who need to be involved in the M&E processes within a country. And therefore, even as we continue with the sub-community, it's upon us to invite, co-opt people who we think we need as critical stakeholders. I would have paused here and asked who are involved in your country, but I'm cognizant of time. So I'll just highlight them. Think about, you need laboratory staff in your team because that's where the testing is happening. Of course, you need the HIV and treatment team in your team. And in different countries, you might find that some of them are split, whereby we have those who are dealing with adolescents and children, others are dealing with adults. So ask yourself, do we have some representation of HIV care and treatment? Are we getting facility level experiences to know what is going on? And of course, you need supply chain management staff. Because remember, you have to think about in terms of commodities that are needed, be they for testing or they are these themselves. And of course, then you also bring the M&E team, what I'm calling the strategic innovation and monitoring and evaluation specialist, so the team that is needed. So if you have a team that is bringing on board this kind of level of representation, then the conversation on what needs to happen within your M&E subcommunity of practice in country, then the conversation is complete. Because you don't want a situation whereby you gather as a team, but as you're gathered there, you realize, wait a minute, we cannot answer supply chain related question. Or we have no idea what is going on at healthcare, at health facility level, because you don't have some kind of representation. I think what I'm trying to say here is, look at your M&E subcommunity of practice within your country and ask yourself, who else do we need to co-opt so that we can have a comprehensive, complete conversation? Now, as we shall continue engaging, these two resources will be extremely critical for us. The first resource is these technical guidelines or recommendations to consideration that have been put together by different stakeholders led by WHO that recommends on what countries need to consider when they're developing an M&E framework. We continue referencing this document as we continue to engage, and we hope by the time we are done with this engagement, we will have another critical look at this document and ask ourselves, is it time that we updated it? Is it current enough? Now, that's number one. And number two, I would want you during your free time in the course of the next few weeks to look for this article. It's called Realizing the Potential of Routine Viral Testing in Sub-Saharan Africa. I find the article extremely enlightening. The information contained in it is great. But our key resource, as we continue engaging, as we continue having this conversation in the M&E community of practice, is this WHO guideline. And we hope by the time we are done, we'll be looking at it. Now, when we bring the M&E community of practice together, there will be a mix of formal training. There are a number of sessions that we have planned, whereby trainings on topical issues will happen. We are going to have practical exercises based on country situations. So we'll be asking to share, for example, I believe there's a lot Uganda can learn from South Africa, but at the same time, there's a lot South Africa can learn from Uganda. So that cross-country coordination, learning, South-South exchange is highly, highly encouraged. But as you sit as an M&E community of practice, we also need to remember that you need to make sure that you involve as many stakeholders as you possibly can, from government itself, and I all of us were nominated by our respective Minister of Health to be a part of this sub-community of practice, development partners, implementing partners, private, bring these as many stakeholders to the table as possible so that the conversation can be complete. Now, so our engagement will be happening every first Thursday, like this one, but also every third Thursday, we'll be having the South-South learning. So we are going to have a number of sessions on M&E fundamentals. This will be happening on 18th of February. And then after that, every first Thursday of the month, this session will be conducted from the framework to dashboard, to data quality, to evaluations. And the expectation is that besides having this, we are going to have an South-South sharing, whereby we will be having practical sessions. We'll be looking within the country to see what is it that we can support. If there are resources that are available to support small projects, for example, resorts, we shall be doing that. And the expectation by the time we are done with this engagement for the next number of months is that we're going to achieve three things. Number one, we are going to have an M&E framework for viral load. Either it is developed within your country if it is not there, or it is reviewed or a review for the same. Then, for countries that don't have dashboards, then we're also going to work with those countries to make sure that they develop a roadmap to how they're going to have a dashboard, or if the dashboard is there, it is not comprehensive enough, we are going to work together to make sure that we have a roadmap on how we're going to achieve that. And finally, we would want to work toward increasing availability, access, and use of overall data at all levels. But I must insist here, especially at national level, because the policy directions of a country are being, the policy direction decisions of a country are being made at that level. And therefore it becomes extremely important to make sure that that data is available. So this will be our engagement for the next number of months, up to around July. And after we are done with this engagement, we come together, all of us, in a workshop, in somewhere we gather, to celebrate what is it that we have been able to achieve in our respective countries, and what is it that we have been able to achieve as a team. And then look at the various action points that we had set out to achieve. Did we achieve them? Toward the end of the whole thing, there will be certification that will be done after we have gone through the 6 sessions. And that, so we target to have a workshop whereby all of us will come together and basically discuss what progress we have made and look at whether we're able to meet our expected outcomes. And that will be happening toward the end of the year. So mark your calendar. Every first Thursday and last Thursday of the month, we are going to be having a session, a presentation, or it will be a South-South sharing where different countries are coming in to speak about their best practices. Now, and all what we are saying here, I want to borrow this quote, is that while we cannot really say we are managing knowledge, what we are trying to do is to create it, discover it, capture it, share it, and validate it. Eventually, we have it adapted and applied in our respective countries, borrowing from experiences that we are bringing on board. This is not a training per se. This is an engagement between expertise, people who are coming from different representations, different countries, coming together and strengthening the system together so that we can all learn from each other. Thank you so very much. I'll hand it over to Collins.
Thank you very much, Michael. That's very informative, starting from where the self-assessments revealed, going through the assessment that you did for M&E specifically with the countries, sharing the results, and also introducing the M&E subcommunity of practice. So now we have like 10 minutes, and if anybody wants to raise any question, I think you can come in at this time. In the chat box, there are a few comments. There's Miriam Nabukenya. Miriam, are you able to unmute so that you tell us your experience from Uganda? If not, yeah, Miriam, go ahead.
Yes, please. Thank you so much for that wonderful presentation. Well, facing a big challenge with regard to linking up data from counseling, from those counselors to the main database. And that's why whenever you can look for what happened, like we're trying to gather data around those repeat tests and find out whether those clients actually resuppressed after intensive adherence counseling, but getting that data is so tough. We have no access to it. And the worst is, at least at facility level, they usually do capture some data, but even what is captured at facility levels usually is not documented so well. Some files are never kept so well. Like there's something that is really needed to do so that we can try to at least rearrange our facility data before we can even think of integrating that data into the main database. Yeah, but there's something that we're working on. I think I'll share it tomorrow as we'll be sharing our updates that we've tried to come up with to see how better we can solve that problem.
Thank you, thank you, Miriam. Michael, any comment, follow-up?
No, I don't have comments, Lily, just to thank Miriam, and it's good to hear experience of Uganda. And as we continue engaging the next number of months, we'll be looking forward to basically learn from each other to see what is it that is realistically possible that we can improve on, what is it that we can learn from other countries, and we only bring all those experiences to the table. Then I believe we are going to make a lot of progress as a subcommittee of practice. Thank you.
Thank you, Michael. Elvis, you can unmute and ask your question.
Yes, thank you. I think my question is to Michael. Now that we are going to develop the M&E framework, do we need country-specific viral load strategic plan so that it can be monitored using this?
So thank you, Elvis. I would leave the decision on what is needed to the country to make. What there is out there, a recommendation, for example, from WHO on what consideration a country need to have. I'll be very hesitant to prescribe the country, but the country need to ask itself, what is it that we need? What do we need to improve? How do we improve it? What resources exist out there? Who can we learn from? And on the basis of that, then the country makes a decision on what it is they want to intervene. Thank you.
Thank you, Michael. Eruna Etubi, go ahead. Eruna?
Yeah, good afternoon, everybody. And I want to actually thank Michael for that wonderful presentation. I'm from Nigeria, the Federal Ministry of Health. Actually, I want to know for how many months this last time we had some discussions and a meeting too with the M&E. We were able to talk about some things. So here in Nigeria, we have our LIMS dashboard, and we feed into the LIMS dashboard from the PCR labs. And then we've tested and result retrieval, it's a little bit okay using the remote sample login. We still have just this, and we can get our data straight. I would really want to see how this could be forward, knowing from data on the dashboard. Thank you very much.
Thank you, Eruna. Michael, did you get that?
Yeah, she was breaking a bit, but I think if I got the first part of the question was asking on how long are we going to engage? And the plan is that we are going to be having a presentation the last presentation is scheduled to happen on the first week of July. So we are going to have a main presentation in the month of February, then March, April, May, and then final one in July. Those are 5 sessions that are planned. Those are topical or conversations. And then in between there, from the month of March, we're going to have 4 South-South learning from countries. And so by 1st of July, that is when we shall be having our last session, which will then be planning on when we shall be coming together in form of a workshop, bring all of us together to review the progress that we have made, both as a sub-community of practice and as a country team, for the progress that we have made within your action plans. Thank you. And the second comment about the dashboard, I think as we continue sharing, there's a session that will be looking at the dashboard. As we continue sharing, then we shall be seeing what exists between the various countries and how can various countries learn from each other. Thank you so very much.
Thank you, Michael. There's also a comment in the chat box from Amina from Cameroon. She hopes that we'll be able to learn from other programs. I don't know if she wants to speak. Amina, you can unmute. If not, Somaya, did you want to make a comment before we end? Amina, go ahead.
Okay, thank you, Michael. We just want to thank you for this wonderful presentation. We saw how an M&E program will be very helpful for putting in place a good viral load program and in extension for a better laboratory network, national laboratory network. Thank you very much.
Thank you, Amina.
Thank you, Amina, so much. Okay, we are at the top of the hour. So I think if there are any other questions, we can forward them to Michael. Just to make a few announcements. One, that we will be able to support some small grants for some demonstrations within this M&E sub-community of practice. So if we could get your plans, I think that would be good. Then for the LabCoP leads who are here, we also sent an email asking for updates from 2019 on what was funded, which activities were funded and which were remaining, and also an update of the 2020 work plans. Otherwise, Michael, I give you a minute to speak before we close.
So thank you, Collins, and thank you, team. And I must say that I'm looking forward to this journey, us engaging, discussing. I really appreciate the expertise that is in this forum. And I'm very sure that when we continue sharing, we are going to improve the M&E across the various countries. I have seen a comment that this presentation is heavy on lab. And I think is by design, because we are trying to sort out the M&E for laboratory and we have used VL as the entry point. I've seen a comment on whether the presentation will be shared. Yes, the presentation will be shared. I expect to hear from me almost immediately. You'll get the presentation, and both the presentation and the recording. Thank you. Thank you, Collins, and over.
Okay, thank you. Hail Mariam, we have noted your comment and we'll be able to respond. Colleagues, thank you for attending, and we look forward to the next M&E session. Thank you so much, and goodbye.
Okay, thank you. Goodbye.